moving on to talk about the next branch of the vasculature, which are venules and veins. And we just want to remind ourselves here of the overall makeup of the vasculature. Arteries on the proximal end, arterioles, capillary beds, which we just described. Now we're getting into moving that blood, that oxygen-poor blood, back towards the heart. It's really important to get that back into the heart so that we can have more projectile force to send it into the lungs to be reoxygenated. So we've described generally some of the features on this side of the vasculature. Now we need valves. We're trying to go back to the heart, usually against gravity. So now we're going to need valves. And then overall, the makeup of the vessels here are a bit different. They have more of a capacitance. They can hold more volume. They have a thinner wall. And then they also are going to be lower in pressure than the arterial side. So let's start off with venules. They're smaller than arterioles. They connect capillaries and capillary beds to bigger veins. They have a little bit of smooth muscle in their wall that becomes important. We'll talk about why later on, but that does help with the movement against gravity. So they're not devoid of smooth muscle in terms of their wall. And then there is a small bit of exchange happening between the blood and interstitial fluid. So some of those forces we described on capillaries are still at play when we look at the venules. So very small exchange still happening with that thin wall and small bit of smooth muscle. Veins, on the other end, are going to have a larger diameter, thin wall, and then valves, right? The bigger veins are definitely going to have valves to keep blood moving in one direction because pressure is not as high and because we do have more volume. They're going to be present more so in our peripheral veins, veins that are in our limbs, so lower extremity veins, upper extremity veins, while they are mostly absent from our central veins, like your inferior vena cava, your superior vena cava, your jugulars. Those have pretty good flow and smooth muscle to help with that venous return, so they don't necessarily need valves. Veins are the compliant vessels. And remember, we talked about this word compliance. You want to take this word at its face value. It is obedient. It's going to obey when there's more volume. So very little change in volume results in change in pressure. Excuse me, a larger change in volume is required to result in change in pressure. These are very low pressure, but they can accommodate a very large volume. So they expand with very little change in pressure, right? A lot of volume, little pressure. And then they can act as a blood reservoir, as a volume reservoir. This is where most of the blood in our entire vasculature system is sitting. It's in our veins. And then 60% of our total volume at rest will be in these vessels as well. So just to compare that, arteries to veins, and we're comparing the volume in the vessel to the distending pressure. So if you look at arteries, right, we have a small change in volume to bring about a large change in pressure and to distend or expand these vessels. This is where we talked about that elasticity. So a little bit of volume creates a lot of pressure in these vessels. In veins, it takes a lot more volume to give us the same amount of pressure as we see in arteries. So veins are very distendable. They can accommodate a larger volume without having a larger pressure inside of them. Okay, so they are much more capacitant or compliant. Now, looking at the overall distribution of blood volume in different parts of the body, so 60%, and this is at rest, right? Obviously, we're going to have some diversion and shunting of blood with exertion, but at rest, 60% of that volume is sitting in your venules and veins, about 15% in your arteries and arterioles, about 12% in your pulmonary capillaries and vessels, and then the heart has about 8%, capillaries about 5%. So a large majority, more than half of the volume in your body is inside your veins. And then what are some factors that help with that venous pressure, right? Because we don't have as much pressure on the venous side, and we do have a lot of volume, again, moving against gravity, we have valves here, so one-way valves, especially in the limbs. We also have the skeletal muscle that's contracting also in those limbs that are going to squeeze on the veins, increase their pressure, and help to move blood back towards the heart. And then we also have the skeletal muscle relaxation in between. So not only do we have contraction when the valve is open, but when the valve is relaxing, we have relaxation so that the blood does not have an opportunity to move back into the previous part of the vein. So when there's contraction, the valve is open, and when there is relaxation, the valve is closed to prevent that backflow. Okay, so here is what we mean. So here is your skeletal muscle that's contracting. When the contraction takes place, like when you're walking, running, jumping, the valve is open. This is what allows the blood to move in one direction. The preceding valve is closed, and the valve that is beyond or distal, or in this case proximal, that's going to be open. So blood can move towards the heart. In the other end, when the muscle is relaxed, the valve is closed while the preceding valve is now open. So blood can move into this space because the muscle is relaxed, but the distal valve is going to be closed. And so we can trap blood in this vein, this part of the vein, until the next contraction. And then we're going to close this preceding valve and move the blood along. So this somewhat acts like peristalsis. And peristalsis happens in your gut, in your GI tract, and that is what keeps the blood, the food moving in one direction. So a similar phenomena happens here with the skeletal muscle and the valves to create this skeletal muscle pump that moves the blood in one direction. Another phenomenon that happens that helps to move blood against gravity back towards the heart is the respiratory pump. Now, the respiratory pump is a combination of your respiratory cycles along with the state of your thoracic cavity and abdominal cavity and the pressures in those cavities. So when you take a deep breath in, this is inspiration, your diaphragm flattens out, you decrease the pressure in your thoracic cavity, and you increase the pressure in your abdominal cavity. And you can almost feel that on yourself. You take a nice deep breath in, you feel pressure drop in your thoracic cavity, your diaphragm goes down, and you feel a pressure rise in your abdominal cavity. Now, the pressure that's on the veins creates this gradient. Now you have more pressure on the veins in your abdomen, less pressure on the veins in your thorax, and this allows the gradient created to move blood from your abdominal cavity veins to your thoracic cavity veins. So from your lower vena cava, for example, to your thoracic vena cava. So that gradient created by the pressure changing when you have that change in the shape because of the inspiratory cycle. Okay, and that's going to favor blood moving against gravity from your abdomen to your thorax and eventually back into your heart. Another thing that's happening here is you're increasing the central venous pressure, which is the pressure in your, or the driving pressure that's moving blood back to your right atrium. And then that is also increasing your venous return, which is blood moving back to that atrium as well. Now, we also want to think about the overall change in blood volume. Whenever we have increase in blood volume, there's increased venous pressure. So as more blood pools in those large veins, the small, smooth muscle that is lining those vessels creates an increase in venous pressure, and that in and of itself clamps down on the vessel and helps with that flow back towards the heart. Alternatively, when there's decreased blood volume, that smooth muscle tone decreases, and that will decrease venous pressure and venous return. And then the long-term regulation of this is that um, this is going to take a while to happen, right? So increase in blood volume, increasing venous pressure, this is more of a long-term regulation of blood pressure. So this is going to happen gradually over time, whereas the other two mechanisms, the thoracic pressure along with the musculovenous pump, those are immediate responses to change in your venule, the volume in your veins, right? Your venule volume. So this phenomenon that I've described here with the smooth muscle tension in your veins, this is called your venomotor tone. And venomotor tone is because of the smooth muscle that is in your veins. It's a small band of smooth muscle, nowhere as thick as the smooth muscle in your arteries, but it plays a very important role. It increases the tone of your veins to increase the contraction and increase the force of blood that's moving back towards your heart. Now, this smooth muscle is going to be innervated by your sympathetic nervous system, much like on the arterial side. So we can see regulation by the autonomic nervous system here. This is going to be dependent on norepinephrine, either as a hormone or neurotransmitter, binding to adrenergic receptors that are found on the smooth muscle inside these veins. So when the sympathetic nervous system is excited or elicited, we're going to have constriction because of this response that contracts the smooth muscle of the veins. This is going to increase your venomotor tone. That will increase pressure in the veins, which increases your central venous pressure, which decreases the compliance. So now the vein is not as obedient. It's going to give some give back because of that venomotor tone. It's not just going to obey and open up. It's going to have sort of a snapback because of that contraction of the smooth muscle inside the vessel. So now with this venomotor tone, we see a small decrease in venous compliance, which actually helps to aid venous return. All right, because if the valves are too compliant, then it doesn't give enough pressure to get that blood moving back towards the heart, right? So there are instances, especially fight or flight, when we need to have more volume coming back to the heart. Remember, more venous return equals more cardiac output. And so in order for us to have cardiac output increase to match the demand that's required for the sympathetic response, we need to have more of that blood making its way back into the right atrium so we can have more cardiac output. So this is a part of the sympathetic response, which decreases the compliance and increases venous return. So let's walk through that flow of events. So let's say we're in fight or flight or freeze mode. We have activity of the sympathetic nervous system, specifically the nerves that are innervating the smooth muscle within the veins. That increases the venomotor tone, which decreases the compliance because now we're pushing back against that blood in the vein. That is going to increase our venous pressure. And as a result of that, we're going to see increase in blood volume. We're going to see increase in the activity of the respiratory pump, and then increase in the activity of the muscular pump. So all three of these mechanisms will be elicited as a part of increasing venous pressure, and all of these favor more blood going back to the heart. And we're going to talk later on about mean arterial pressure. We've already talked a little bit about mean arterial pressure as it regards to arterioles. But mean arterial pressure, which is the pressure that is perfusing your tissues, your arterial pressure, that relies on venous pressure, right? That same connection that I made earlier with venous return and cardiac output. If we're not getting blood flow back to the heart, we're not getting enough of that volume coming back to the heart, we're not going to have enough cardiac output, and we're not going to have enough mean arterial pressure to drive perfusion on the arterial end. So now we're going to see increased venous return, more blood entering the atria of the heart. That increases atrial pressure, which increases end diastolic pressure or preload. right? Remember, at the end of diastole, the ventricle needs to have filled enough in order to eject enough. That's your end diastolic pressure. And if there isn't enough venous return, the ventricle cannot load or fill enough to adequately eject. So this is all connected. And so now we have a raise in that end diastolic volume because of an increase in end diastolic pressure, and that results in more stroke volume leaving the heart and more cardiac output moving towards our peripheral tissues. That will increase our mean arterial pressure or the driving pressure on the arterial side. Okay. So when we think about veins, we also want to think about how they drive the blood back towards the arterial end. Very important for our overall circulation and perfusion.